a 76-year-old male with recent CHF exacerbation. So he has pretty severe heart failure with preserved ejection fraction. His class 3. So he has pretty severe symptoms. He was past medical history of hypertension, type 2 diabetes, permanent atrial fibrillation, chronic kidney disease, and thalassemia minor. He lives alone and he uses a cane for ambulation. He was admitted previously in March to Los Robles for exacerbation of his heart failure, and he was readmitted now due to failure of outpatient therapy. So despite Bumax outpatient and Gold medical therapy, he came back in. He has worsening heart failure due to severe mitral regurgitation, and he was considered high risk for surgery by Dr. Fontana, a cardiothoracic surgeon. So now Dr. Carr will be doing a MitraClip.
As you can see over here, there's the LV function is preserved, the left atrium is enlarged, and you can see mitral regurgitation is eccentric, but I didn't want to show you all the details. We're going to show live TE. This patient is in basically refractory heart failure. He has had 2 admissions in the hospital for 3 weeks onwards with a high creatinine of 2.9 with morbid obesity. So he was considered to be extreme to high risk for open heart surgery. And I'm sure most people would consider that.
Yeah, our most instructive image here is the mitral commissural view here. And you just put color on here. You can see a jet, the prominent jet that we're going to be going after, and see what we're left with after is this jet right here. If you look at my pointer right here on the P1 area, and the lateral aspect of the valve. And often you can underestimate this because you don't see it going up into the atrium, but if it's going across the valve from the lateral to medial direction, and it is a significant jet, classified as moderate to severe at least. And if you go from here, we can go X-plane and give us an orthogonal view, and this is where kind of our grasping view will be.
Can you show us a good X-plane image of what will be my line of, how am I going to...
grasping view, yeah.
Grasping view, because I want to understand it, because it's actually quite challenging. But that's not the right angle, right?
Yeah, so we're going to, well, that's the 90 degrees, but we're going to have to kind of decrease the angle, right?
Yeah.
Since it's so commissural.
So
again, we start with that 3D image. Orient it correctly. And we hit the multi-view function. We're using a Philips machine here.
So what he's trying to do is trying to reconstruct the images. This is a very nice view, actually. The 3D on the right lower corner shows that little prolapse there.
Mm-hmm.
You can bring the red line right over that prolapse.
Yes.
And then you're going to go, that's the midline, and now you're going to draw the red right over that commissure. And in the right lower corner, you can see you can already turn the orientation appropriately.
Yeah, so I think when we go grasp, it's going to be like this.
Yeah.
Just kind of perpendicular to the coaptation line.
And that's where you can see the P1 flail.
And there it is, yeah. And then if you look in the top right image, and I'll maximize that so you guys can see, but that's where the flail is, and you see the torn cord flickering every now and then as well.
And put color on there. And that's the Pisa. So I think you can go even more lateral. I think I should try to go as lateral as possible.
Right. Yeah, but you can see this is always a cord-rich area, and so we've decided, Dr. Carr, right, to go with a narrow, short clip.
Yeah.
Yeah.
So we have done the transeptal in the mid fossa and in posteriorly.
Mm-hmm.
We have enough height, I think. We have 2 catheters across the septum. We have a pigtail catheter, which is measuring the left atrial pressure. Is that wire?
You have quite a bend in the wire there, Saibal. Do you see that?
I don't know why that's so bent. Okay, just bring it.
There you go. You've straightened it out. Yeah.
Yeah, okay, good. And then I'm just going to go slowly in.
And you can see the tip of his dilator coming across now.
And I think I may have gone in already.
Yep.
Okay, good. So the guide's inside, okay?
So in the MitraClip system, you see what we call zebra lines here. And that shows us that that's the dilator. And then this is the tip of the catheter, the guide here. So he wants to make sure he has enough guide across so when he pulls out the wire
just keep it
and dilator, the guide will be in the left
is,
atrium.
So first I'm getting the dilator back which shows that my enough guide is in. And you can see that the left atrial pressure is grossly elevated with a very prominent V wave. And the V wave is around 48. And this is after anesthesia, after diuresis for 4 days, IV diuresis. So this is, he's in such bad decompensated heart failure. And we think that a contributing factor is his diastolic heart failure, obesity, as well as the MR. So I'm going to advance the clip in. I've got the guide inside nicely. And now I'm just going to go with the clip. So the clip is going in.
You can see the clip coming up there, and it's out.
And now I'm just going to go flex it in.
And so you watch him here at this point trying to avoid that Coumadin ridge between the pulmonary vein and
the guide, like this, and hold
left
it like
atrial appendage. And he is hitting it there, but I think he just cleared it.
See, I'm bringing the clip down. See
Good.
that?
So now he's coming down towards the valve, and I'll go to an X-plane image. Often they're anterior in this, and that's where he is there. You can see him in the right image.
I think the position looks great, right?
Really good. Yep. So we'll go ahead and orient the clip.
See that? We're on the lateral part. All right. So the clip is open, and you see I'm trying to look at the clip orientation. So we need to go a little bit more lateral, correct?
Yep.
So lateral means I'm advancing it. See, I'm going and advancing a little lateral. And also, you see the orientation is almost perfect, but a little bit counterclockwise. See, it's a bit off. Like I want to get it like this. I want to get it like 1 and 7. See that?
Yeah.
So I'm just going like this, and I'm just. So I like that position. What do you think? So.
I think it looks good.
And then I'm going to come back a little bit more, go in more. So a little bit more lateral, because it's right in the commissure. See that? And then you see the clip wide open. And I like that position actually. And I'm just going to test the grippers now.
I think it's good, yeah.
So dot is anterior and blue is posterior. See the grippers coming down?
Do you see that gripper in the posterior one? It did not look like it came all the way down, not as far as the anterior.
I'll show you.
Maybe cycle them a little bit. They might be a little stiff. Do you see that, Saibal?
That's okay. That's all right. I think that's okay.
Yeah, I think you're lateral enough, Saibal. You see PISA.
Okay, because remember, I want to be as lateral as possible.
Yeah, you don't want to leave anything, yes.
I don't want to leave any gap, and then I can always put another
you can also see the pathologies hitting your clip there too, right? So I think this is a good spot, Saibal.
Okay. So I'm still trying a little bit more lateral. Okay, I'm going to clockwise the catheter. See that? So it goes in this way. Then I'm going to close the clip. See, I'm closing the clip. See that? And now I'm going to advance the clip. And as I'm advancing, I'm going to see that it doesn't dive. I like that position. Maybe I can come back a little bit more. You see how it dived? I'm going to take off a little bit of lateral movement to go below, because it's tending to dive in medially. See? So I'm taking it off a little bit. These are particularly challenging to do because it's right in the corner.
Yeah, there's a cord right under. There you go. Perfect. Don't advance anymore. That's great. I think you can clock it a hair, yeah.
Okay. See that? The orientation I'm just wanting to be, because it's in the corner. So we wanted like 1 and 7.
And if you look at that red line, that's kind of our grasping view. So now it's oriented perfectly.
And then we want to go, I just have a feeling we should like to go a little bit more lateral, if possible. I know the leaflets are fallen nicely on it.
Yeah, the posterior leaflet's getting hung up a little bit on the shaft there. It's not diving it in, yeah. There you go.
See, now both the leaflets are on.
Yes.
Right? And
Very
I can
nice.
drop the gripper. Okay.
I wonder if you could optimize posterior a little bit, don't you think? Or
I can optimize. Okay. Okay. I'm going to clockwise this catheter, and you're going to hold it for me like this. Hold it like that. And then I'm just going to pull up.
Yes.
And I've got a lot.
You got everything. Yep.
Okay.
Beautiful. Look at your orientation, the bottom left image. Do you see that? That's exactly what you wanted.
Okay. So shall we close and see what happens?
I think it's great.
And watch LA pressure if there's any change. And the LA pressure is slowly coming down.
The window Dr. Carr had to make it through in this one was so small, and he did it perfectly. It was really good.
And the LA pressure has come down. Did you see that?
That's nice job.
So that's beautiful. You see, remember there was this horizontal jet going through. And I didn't even notice there was a very tall V wave in the LA pressure lower down there. Really? And then it came down.
That orientation is nice.
So I think the results good. Now people will get worried about all those vertical jets, but those aren't from a different spot, right? So I would just do.
Yeah, we want to
yeah.
make sure there's nothing lateral.
But and you what is nice is to say that there's no jet going lateral to medial, and there's
Agreed.
no jet lateral to the clip. Are you
Yes,
correct with it?
I agree with both of those assessments. Yes.
And now what we can do is proper 3D end phase and show that comparison. And if then it's okay, we should deploy this clip. But I think the MPR imaging was so helpful for this case.
Yes. There's a pretty good grasping view in the
You see?
top right or in the right
And you
image.
see the posterior leaflet is in. You see how the two leaflets are in. And it's very important to see that you can see this. And we know what a nice thing on MitraClip is that you're very relaxed. Look, we're standing over here, we're chatting, we're not doing anything, we're just watching things go because you're taking time. There's no stress. Now the LA pressure, you can see it's blunted, but this diastolic component has reduced. Do you agree with that?
Yes, yes.
And now this is the right pulmonary vein. And you can see this is actually quite nice. You see that the systolic dominance, you see the systolic phase, it was much more blunted before. It's actually
It's on its way to being co-dominant.
Yes.
Yeah.
Okay. We go to 4 stages. We first see leaflet insertion, then we see color change, then we look at pulmonary vein flow, and then we see gradients. Now, if the gradient is more than 4 or 5, then we think, wait a second, we should not deploy this clip. But here the gradient looks, it's nothing. It's very little.
So the gradient was 2 to begin with. So that tells you you've addressed some of the flow, correct?
Yes.
I'm just going to come up above the clip here.
Yeah, and see
in the 0, see if I can see any jets, and then we're just very systematic about this, right? There's no rush.
And you can see this. Look, the jet is going up vertically. When it was severe, it was going horizontally. When you see a vertical jet, if you see a horizontal jet, a wall hugging jet, it's always significant. When you see a jet going back just straight up and down, it's not.
So when I pull up above the valve, above the clip, meaning more lateral, I don't see anything.
See that? There's nothing. And then as you go deeper inside,
there you start to see the jets.
Medial. So that means I can just put another clip there if necessary.
Yes.
All right. So we can decide that, but
all of these are very small on their own.
Yeah.
That one's probably the most significant one.
Yeah. But it's quite far away from the clip. So let's deploy this clip, okay?
I agree with you.
So the 4 things that for teaching sake is, remember I told you, leaflet insertion, we saw that very well. Color reduction by MR, pulmonary vein flow improvement, and the gradient. And then we do a 3D end phase to actually show the bow tie of the valves. You see, it's so beautiful. It's right in the corner there. We took care of it right in the corner. Normally, and that's the nice part when you're doing these commissural cases, is the orifice valve is left open. So there's no stenosis. The downside is that on the sides, they're very difficult because there are lots of cords and you can get trapped in the cords. That's why we used a narrow clip. Yeah, that's good. Try to open it up and watch fluoro as you open it up. See, keep going. And it's not opening. Keep going to loose till it's loose. So it's loose now. And then I go positive side of neutral. Okay. That means it's not opening. So then I take this off. See that? It's just wrapped up. It's just a manual thing. Well, I'm just trying to get this knot out. Okay, it's got it. And then what you do is you hold this like this and take out each thread, and then I do like I floss it. See that? I'll do floss, and then it's dot there. It's open. Now you can just start pulling one of the threads, fluoro, and the clip is not opened, right? I'll keep pulling, keep pulling. That's it. That means the lock is closed. So I tighten the lock again, and then I try to open it again, and look, it doesn't open at all. See that? This is the pin. And I open this 5 times till I can see a groove. You see, I see a groove there. Yeah. Now do 8 times counterclockwise. Count it. You see the arrow there? Yeah. Counterclockwise. Yep. And 8. Okay. And then you just pull this back, and then you see the clip is deployed. So let's look at it and see whether we need to put one clip. But I don't think, I can't put a clip on the side because then it'll become stenotic. So it's a bit tricky, that what do we do with this patient?
Maybe you try to put one kind of on the lateral aspect to the valve. I don't think right next to the previous clip because there's no pathology there, but
I know.
Right here there is.
All the vertical jet is gone. The prolapse is actually gone. The only question is there anything here that I need to do?
There might be a little bit of prolapse there. Do you see that?
Yeah.
Posterior?
No, it's going up, right? It's vertically up. There's no, if it's prolapse posteriorly, it should be
Yeah,
an
should
anterior,
go anterior. Yeah.
but it's
Mhm.
not. So I actually don't know whether it'll be a benefit. But I mean these small jets, I don't know whether I can help them. I don't think it's going to
Yeah,
help.
you certainly address the eccentric jet.
Yep. And I think that's all we can do for the time being. This is what people try to do. They try to fix the middle valve and then they cause the valve to become narrow and then the air pressure goes up and the clip looks very stable. Yeah.
Yes.
And look at how the leaflets are coapting very nicely in the middle.
Yeah.
And look, there's
There's
all
no
these
obvious pathology
yeah,
here. Yeah.
there's no pathology like in a flail or prolapse. And you see that they're far, and the first jet is far away from the clip.
I mean, I think if you address one part of the valve with, you're going to keep chasing jets.
Yeah, then you're just going to convert a normal orifice valve into a stenotic valve.
Yeah.
I don't want to do that. Yes, and you can see how beautiful it's in the corner, so you can't even see the clip. What's his blood pressure now?
115/54.
Okay, so he was actually lower when we came in. It was in the hundreds, so the pressure went up.
It did go up about 10 points. Yeah.
Exactly. So that's good, very good. So that's an important sign of improvement.
Good forward flow now.
Yeah. So I'm going to take the guide out. We're actually ready to close the groin.
I'm debating with myself what is he left with? How much MR?
Yeah.
It's either mild or mild to moderate. You know.
I would say it's mild to moderate for
Yeah.
sure. Okay. We're in the RA now, and the RA is still very high too. His RA is 24. Wow.
So he could
he
be
needs to-
diuresed.
he can be diuresed much more.
Yeah.
So all these guys were saying that not to diurese. It doesn't make any sense. All right. So let's just pull this out. These are very challenging cases.
He had this effusion to start with in case anybody's
Yeah.
concerned. You know.
Yeah. It was there before. And the RB and LA are the same.
Part of our initial assessment, we always look for that kind of stuff. So.
You see that? His aortic valve is also narrow. It's not critical, but it's definitely narrow. But it's not less than 1. I think we can give up protamine because his procedure was very fast. We're actually already done. I'm just putting one. I only use a single perclose in these cases. Even though he's an obese patient, hold the pressure. And it doesn't matter. We just do a figure of 8 stitch. So I'm going to do a figure of 8 stitch in the subcutaneous space. Even though the bleeding is almost stopped, but this is an extra guarantee that I do. So there's no bleeding at all. And then we just do this. This is called a fisherman's knot. So before we end, we'd like to summarize this case. This was a very sick individual. As you can see, in refractory heart failure for months, readmitted with heart failure, had MR severe from a eccentric jet from P1, has moderate aortic stenosis, has diastolic heart failure, has chronic renal failure with the creatinine 2.9, who now has underwent a successful MitraClip procedure. With one MitraClip, he's left with mild to moderate MR, which is not related to the original pathology. So we think this is good. We did a transeptal from the femoral vein, and you can see we have only a single stick, no bleeding at all. We have just anesthesia, we're going to extubate. And we would like to thank everybody and thank all the members in the team over here.